Well, hello and welcome or welcome back to this ongoing series, Autism Spectrum Disorder in Three Dimensions. My name is James Coplan, MD, and I will be and have been your guide through these materials. If this is your first visit, I encourage you to go back and get yourself caught up on some of the prior material. And if you've been following all along, then you will recall that last week I introduced the third axis on the graph, which is time. So now we have a way of thinking about the combination of degree of atypicality, level of intelligence, and time, and the progression of symptoms within that three-dimensional framework. And what I'd like to do now is jump in and pick up where we left off last time. And the place I'd like to begin is with this quote by Bartok and Reuter, which dates, if you see the fine print at the bottom, from 1976. And what they wrote at the time was, in terms of scholastic progress, social competence, and work opportunities, the child's IQ level is as influential as the presence of autism. So this is not an idea that's new with me. It's been around for a long, long time. My contribution, to the extent that I've made one, is to take this observation and try to express it in a systematic way. My book came out in 2010, and up till that point in time, there had been at least 10 studies numbering over 1,000 subjects, and all of these studies are reviewed in a extensive table within the book, but suffice it to say that they encompassed at least 1,000 children, or at that point in their lives, adults. And it was very clear across all of these studies, numerous authors, slightly different methodologies, but the point was uniform, that children who were in the IQ above 70 range did substantially better than children who were less well off in terms of cognitive ability. And across all of the studies, about 10 to 15% of these children eventually outgrew diagnostic criteria for spectrum disorder. Now, that doesn't necessarily mean that everything was fine with those individuals as adults, but what it means is using the strict criteria in force at various times when these studies were done, they may no longer have met the letter of the textbook, so to speak, in terms of criteria for a diagnosis. And if you want to read up on those studies, I've detailed them in my book. I do want to share with you one study that a colleague and I undertook when I worked at the Children's Seashore House, which is part of the Children's Hospital of Philadelphia. Here's, and you can get this paper, actually, if you go out to Google Scholar. The title of the paper is Modeling Clinical Outcome of Children with Autistic Spectrum Disorders by Coplan and my colleague Abbas Jawad. And if you go to Google Scholar, I was delighted to see that you can actually get a copy of the entire article for free, which is very nice. So here's a picture of Children's Seashore House. The name is very interesting because in the late 1800s, the good people of Philadelphia decided that they would build a hospital for children with disabilities, but they wanted to put it as far away from the other good people of Philadelphia as possible, so they put it down on the New Jersey shore, hence the name Children's Seashore House. But over the course of a century, the attitudes towards people with special needs underwent a complete transformation. So the hospital down the shore, which had been rebuilt at least once, was torn down, and the children and care providers were brought back into Philadelphia, right next to Children's Hospital of Philadelphia, which now owns Children's Seashore House. But the name stuck, so it's still called Children's Seashore House, even though it's in the middle of Philadelphia. And my office would have been just about where you see the red circle. I was there from 1997 to 2004. And in 2004, I submitted a paper along with my colleague Abbas Dawad, which consisted of a review of all of the children that I had seen during my time at Seashore House from 1997 through 2002, when we actually, that was the data window that we were looking at. All of the children that I had evaluated who met criteria for autism spectrum disorder by what was then the DSM-4 was the reference standard during that time period, and who had had at least one administration of an instrument called the Childhood Autism Rating Scale, known by its initials, the CARS. And this is a kind of a rough and ready clinical measure of the severity of a child's atypical features. The DSM at that point did not include any qualifiers for severity. You either met the criteria for diagnosis or you didn't. PDD-NOS was kind of a surrogate for severity. Kids who weren't considered to be severely enough impaired to meet a label for autism were often classified as having PDD-NOS. But the CARS was available, and I was a big fan of administering that to get some handle on the severity of expression of a child's symptoms. So this study looked at the children that I had evaluated during my time at Seashore House who had had at least one administration of the CARS and who had met criteria for autism spectrum disorder. There were a total of 91 children, and you can see the breakdown here: 84 male, 7 female, so the typical male to female ratio prevailed. 73 or 80% were Caucasian, 13 or 14% were African American, and another 5 were various other ethnicities. This next slide is a little bit busy. Don't get overwhelmed by it. I'm going to walk you through it. The first thing that I did was to sort the charts into 2 piles. Those children whose initial developmental quotient, or IQ, was below 70, which is, remember, that's 2 or more standard deviations, or more than 2 standard deviations below the mean, and those children whose initial developmental quotient, or IQ, was 70 or greater. So those are children whose measured IQ, or whose proxy for measured IQ, the developmental quotient, was somewhere within the normal range. I didn't try to break it down any further than that. And you can, if you look here, what I'm looking at is the distribution of male, or rather gender and ethnicity across the 2 groups, and there was no significant difference. In other words, the children with the lower IQ weren't preponderantly male, and with the higher IQ preponderantly female. The age at first visit was not significantly different between the 2 groups, although you can see that the lower functioning children, kind of paradoxically, their age at first visit was 48 months, a little older than the children who were doing better. And I'm not quite sure why that is. It may have been because they were having difficulty in program or not making progress, or for some other reason the parents may have wanted a second opinion, but that's speculation on my part. The next line is interesting. It's the number of visits. Now, you can't have a quarter of a visit. It says 2.24 visits there, or you can't have a half a visit, 2.5. But remember, that's an average over 91 children. So some children had 6 or 7 visits, some had 1 or 2 visits. So the average number of visits was about 2.25 to 2.5 visits. I know that sounds kind of funny, but most kids were seen at least twice, and some were seen many more times than that. The average length of follow-up was just a touch under 2 years. So the time window during which a child would come to see me and then see me again and see me again was typically a 2-year window, although there were some children that came only once, and there were some children that I saw every year. They came religiously for the entire 7 years that I was at Seashore House, and some of them actually looked me up when I was in private practice out on the Philadelphia Main Line and continued to remain under my care in that setting, although their later data do not fall into this study. And here we have the values on the Childhood Autism Rating Scale. Now, I don't have a slide for the cars, but just think of it like golf. For those of you who play golf, the lower your score, the better you're doing, because it's a count of the number of times you had to hit the ball to get it into the 18 holes. So the cars has a maximum score of 40. And minimum score of 15. I guess 45, not 40, my mistake. But the lower the score, the better you're doing. And the higher the score, the more symptoms you have. And what you see here is that, well, obviously, there's a highly significant difference in the initial developmental quotient, but that's because that's what I wanted. I had sorted them into two piles, and you can see that the initial developmental quotient, or IQ, in the first group was about 50, which would be in the range of moderate intellectual disability, whereas in the higher functioning group it was 86, which is in the low average range, although there were some children who were in the superior range. The average was about 86. And then you can see here that there was actually a bit of a difference on the CARS scores. The children who were lower functioning intellectually had slightly higher scores on the CARS than the children who are higher functioning intellectually. So although we try to think about IQ and atypicality as being totally independent, in fact, in this sample, they weren't quite totally independent, because the higher functioning children from a standpoint of cognitive ability tended to have slightly lower CARS scores at the get-go. Don't get too tangled up in that, but just keep that somewhere as a footnote in your mind. And the bottom line, well, before we get to the bottom line, there was no significant difference in parental education or occupation between the two groups. That I don't think I showed that in the table, but overall, this was a pretty high functioning group of parents. 80% of the families for which we had available data had at least one parent who had completed college or graduate school. 56% included at least one parent who was an executive in business or a higher level professional, physician, attorney, architect, and so forth. And I think what this tells me is that the same thing happened at Children's Seashore House that happened to Leo Connor, or that happened to Hans Asperger, which is that the people who came to the tertiary care medical center for their second or third opinion tended to be people of means, tended to be people who were more well off, who had greater access to the system one way or another, as opposed to the people in the urban environment right around the medical center where I was based. So this was a somewhat disproportionately overeducated, well, not overeducated, but more highly educated than the population average. So here's a table, or a graph actually, and what we have over here is the CARS scores from 0 to 45. There is no score of 0. The best you can have is 15. It's just like if you play golf, the best score you can have, if you shoot a hole-in-one on all 18 holes, the best score you can have is 18. You can't have a score of 0. But the statistical model that we used didn't know that, so in some cases it predicted scores that were impossibly low. Bear with me. But what we did was we threw all of the CARS scores into a statistical model divided into two groups. Remember, the group of children whose initial developmental quotient, or IQ, was below 70 and those whose IQ was above 70. And here what you see is the change in CARS scores over time. The first group was the children whose initial DQ or IQ was below 70. And the second is the children whose initial DQ or IQ was greater than or equal to 70. Actually, it's a bit more complicated than that, because what you're looking at here is not the change in CARS scores directly, but a statistical model that we developed. And I don't want to get all into the statistics and the math. We really aren't in a position to explain all of that here. But the short of it is that we came up with a way of predicting how the CARS scores would change over time for these two groups. And for the children whose initial scores, their initial IQ or DQ is below 70, basically the model predicted no change. And the model held up when we turned around and looked at what those children's scores really did. In other words, the statistical model predicted minimal change, and that's what the data actually showed. And likewise, for the children whose initial IQ or DQ was greater than or equal to 70, we had a statistical model that was able to predict, in fact, starting here with an initial CARS score of 37, and then you subtract from that a certain value based on the patient's age at first visit, and then another value for every successive month of time. And basically, we were able to accurately predict the way in which the CARS scores would decrease over time. What's interesting, to take it down to another level, same data as before, the model predicts minimal to no change in the CARS scores for children whose initial developmental quotient was below 70. And what you see here is I've broken down the children whose initial scores were for cognition were above 70 into different groups. Here are children who were 2 years old at the age of first visit and what their CARS scores did. Here are children who were 5 years old at the age of first visit and what their CARS scores did. And here are children who were 10 years old at the age of first visit and what their CARS scores did, or were predicted to do, and in fact did over time. And what you'll notice, it's fairly obvious here, that among the kids whose IQ is in the normal range, even on day one meaning day one in my clinic, the lower the children, the higher the CARS, or put it the other way around, the older the children, the lower their CARS scores. So even before they, I didn't do any magic by seeing these children. This was a diagnostic visit, not therapy. But what this shows is that the older group came in with a lower CARS score to begin with than the younger group. All of these children being of IQ within the normal range, and for all of them, the trend both observed and then predicted was downward over time. So their golf scores, if you will, got better over time. And now you can make a little more sense out of this, that 0.12 times the age at first visit plus 0.23 times a certain length of time. I don't remember if it was per month, but that's what you would subtract off of a starting value for the CARS to come up with a prediction for what the CARS score would be at some future point in time. Again, it's hard to get into all of the numbers just in this brief blog post, but the point is we came up with a model that was able to accurately predict what the CARS scores were going to do, and they fell into two broad groups. The ones whose scores did not improve over time, being the children whose cognition was below the cutoff of 70, and the ones whose CARS scores did improve over time. Now, the conclusion was, first of all, atypical features in children with spectrum disorder diminish with the passage of time. However, this benefit is not enjoyed equally by all children with spectrum disorder. In this clinical sample, in other words, I didn't have the opportunity to go out and take a random sample of all children in Philadelphia with spectrum disorder. These were just the children who came to clinic. But in this clinical sample, only the children whose global cognitive ability was at or above 70 at entry showed a significant abatement of their atypical features over time as measured by a decline in the CARS score. there was no observed decrease in CARS scores for those children whose initial IQ or DQ was below 70. And these results are consistent with the observations of previous investigators. But this is the first, our paper, as far as I know, was the first attempt to actually develop a statistical model to quantify how much improvement could be predicted on day one based simply on the combination of age and IQ score. So what this brings us back to is the old aphorism, the warmer the water, the faster the ice melts, and you've seen this before. And what we've got is, and I'm going to put the IQ scale first, because down here are the IQ scores below 70, that magical threshold, the cutoff for 2 standard deviations below the mean, and up here the IQ scores above. And remember, the IQ is sort of comparable to the water temperature. This is the warm, this is the cool, and anybody in this range has a score in the range of intellectual disability. And then the second axis is atypicality from severe to mild. Remember, you can have the same degree of atypicality and be up here or be down here. So you can have the same degree of atypicality, but with different levels of IQ. And as we also talked about last time, here's this third axis of time or age. And we have hypothetical child A, who starts out with moderate atypicality, but IQ of 100, and over time his or her symptoms break up. That's the same as what I demonstrated with the CARS scores decreasing. And in contrast to that, the children start out with the same degree of atypicality. Their CARS scores do not substantially decrease over time. Now, one of the limitations of these data, as I've said, is that the patient population was a clinic sample rather than a population-based sample, and it was predominantly upper middle class, and that may limit the generalization of these data across the board. But it's worth pointing out, and I mentioned it at the beginning, that high socioeconomic status, in other words, education, occupation, income, is generally one way of putting the thumb on the scales in favor of a positive outcome. So in any study of development, typically among kids who don't have developmental issues per se, the offspring of higher socioeconomic parents, for various reasons, they have various advantages, tend to do pretty well. And that makes the limited progress of those children in this study even more striking. Remember, I said back at the beginning that there was no significant difference in education and occupation between the kids in the low IQ group versus the high IQ group. So this means that the children with an IQ below 70, in spite of having all the advantages of high socioeconomic status, their CARS scores did not decrease over time. Now, the data that I looked at don't permit us to differentiate between treatment effects or lack of treatment effects versus biologically based differences between the two subgroups. I looked through all the charts, and there was no uniformity in the age at institution of different therapies, or how much therapy, or what kind of therapy. So these data can't be used in any way to say that one kind of therapy led to a better outcome than another, because it was really a whole hodgepodge of different things. And to really do this study right, we would need to have a random sample of the universe of children with spectrum disorder, and then in the ideal, we would need to randomize those children into different treatment groups of standardized treatment and then compare the outcome. But I think that that's not a realistic and possibly not a justifiable expectation. So it's going to be very, very hard to use this kind of approach to validate one form of therapy over another with randomization. Well, I've taken you through a lot of material on this post, and I don't blame you if you feel a little bit wrung out and perhaps a little strung out because talking about intellectual disability within the context of spectrum disorder is a really heavy topic. I realize that, and I'm sorry if I say things here that sound either fatalistic or certainly potentially depressing. I don't mean it to be that way. In some ways, however, I think that if you're a parent and you're looking for some straight talk, you really need some of this information to help ground you in terms of your own long-term planning for your child's future. I'm not saying that, nor have I ever said that we have a crystal ball. We don't. This is a map. And as I've said to every parent in the office that I've ever seen, I can't tell you exactly what route your child is going to take across this territory. And I've had plenty of surprises. Some have been pleasant. Some have been disheartening in terms of outcomes that did not work out as I thought they might. But this is still a broad, general conceptual picture that I think it's useful for you to tuck away, although your task, as was mine when I was in practice, was to get every child to be his or her absolute best, whatever that was. I didn't spend 40 years working with kids with special needs to be a fatalist or a therapeutic nihilist. Maybe I feel a bit defensive about that, but my goal was always to help the child and family be all that they could be. So with that as kind of a closing oratory for today, I think we're going to call it a day. Next week when we pick up again, we're going to drill down in some of the specific symptoms. I'm going to talk about things like theory of mind, central coherence, and social reciprocity, and how those play out over time. So thanks, and I'll see you next time.